So I think you've seen the goal is the simple goal is to try and show you that actually turning our backs on kinetics is silly and we don't need to be afraid of it. And if you find this interesting, one of the recent therapeutics initiative letters that we published, I think it's only 2 pages long, and reading through that would consolidate things for almost anyone. So to make it real, here's a call I got from a doctor who works in Vancouver who was at Dalhousie University with me during rotating internship in 1978-79. And out of the blue, she phoned up, and I guess she got I don't know how she found my email. I guess it's with the college, my phone number, it's with the college. And she said, I've got a 94-year-old woman with a broken hip who has terrible tic douloureux. Carbamazepine helped her for years, but in hospital, because she was taking apixaban, a pharmacist switched her to oxcarbazepine. And the reasoning was that carbamazepine induces metabolism of many drugs, including apixaban, and carbamazepine that the woman liked might have messed with her anticoagulation. But since the change, she's been miserable. So all that this doctor wanted to know from me is, how can I put her back on carbamazepine? And here's a question: can simple pharmacokinetics help? Could you have done what I did, which was kind of rely on my brain? And I did open the internet and look up a half-life. And from the point of view of Dr. Amiro, she felt, I don't really care if it induces anticoagulation induces metabolism of apixaban and reduces anticoagulation. At this point in this woman's life, the only really important thing is she comfortable? And if she's suffering from trigeminal neuralgia, I want to do something about it. So I did look up I looked up the online monograph and found that oxcarbazepine, it really works through an active metabolite. And the half-life of the parent drug is short, it's 2 hours, but the half-life of monohydroxy oxcarbazepine is 9 hours. You don't need to pronounce the name, you just need the main way the drug works is through its metabolite, and it takes about 9 hours on average to get rid of half of it. So I figured, okay, I could also look up after swallowing the tablets, the peak occurs about 6 hours later. That's called the Tmax, and that's usually available in a product monograph. So if we say sometime around 6 hours after her dose today, she's peaked, and now every 9 hours, the dose of oxcarbazepine will drop in half. Then by tomorrow, she'll be down to a quarter of the oxcarbazepine. So if you stop it, if she doesn't take any more after the time of this telephone conversation, you can safely start carbamazepine tomorrow. And it's really as simple as that. We don't need to call an expert. It's pretty straightforward. It's going to decay in some kind of logarithmic fashion for almost all drugs, rare exceptions, alcohol, phenytoin sometimes. And then when she starts taking her carbamazepine again, I'll show you in the next slide how to figure when it would peak. But to get rid of oxcarbazepine, every 9 hours, she's going to get rid of another half of it approximately. And there's variation for every individual for everything in life. So you can't be certain, but this gives you an idea. And now if we look at what about then, how long will it take? I'll come for that in a second. So one of the first goals is to show you how to find an elimination half-life. You can try this in the background yourself right now. Take whatever drug you want and just search, type in the name and half-life, and you don't have to spell half-life with a hyphen. It'll come up instantly. On the right here, I'm showing 3 different ways you could also find a monograph, which is the second route, which is if you want a lot of information about a drug, one used to have to look at the paper in Canada called the CPS, in the US, the physician's desk reference, in Britain, the national formulary, whatever they call it. But in Canada, we call it a monograph. You can find that also almost instantly. Open it and look, say, Control F, half-life, or look for the pharmacokinetics section in the table of contents. And you'll find very rapidly that the elimination half-life of carbamazepine is somewhere in the range of 10 to 20, 16 to 24 hours. So if you apply a rule of thumb of 3 to 4 half-lives, which is this famous graph everyone has probably seen in medical school, somewhere around 4 half-lives, one gets very close to the asymptote. The green line is as high as the equilibrium or steady state concentration is ever going to get, is around 4 half-lives. If you want to be fancy, you call it 5. Oops. And if you wanted to cheat, you could say, well, at 3 half-lives, it's pretty close. 1, 2, 3 half-lives, 4 half-lives. So if you know the half-life, you can predict how long it's going to take to get to steady state or how long it's going to take to get rid of a drug. So hopefully that's clear as mud for you. And if it goes too fast, take a look at that 2-page therapeutics letter. It will be easier, I think, than a textbook, and it has some example videos attached to it. So now the harder challenge is, well, how am I going to convince you that this is worth doing yourself? I think it makes prescribing and evaluation and deprescribing decisions easier. Evaluation as in, for a symptomatic drug, if we know when we get to the maximum steady state concentration in the blood, that's probably going to equilibrate pretty fast with the brain or any other organ. So if it's a symptomatic drug, let's look when we're at maximum or close to maximum, 3 to 4 elimination half-lives. It'll enhance your confidence about stopping or suspending drugs. If we've been through maximum expected steady state concentration and gone a bit further and the patient is no better, what is the point of continuing? Unless you believe that there must be an obligatory delay, which of course is standard teaching for antidepressants, may or may not be true. We don't have time to go into that in detail today. And it'll free you from trying to understand very complex deprescribing algorithms. So let's say it's a Friday afternoon, or you're seeing patients this afternoon on a Saturday. If you can think in terms of simple kinetics, it may think, well, this is a long elimination half-life drug. I don't like what's going on. If I stop it today on a Saturday, nothing bad can possibly happen before Monday. Patient can always call me again on Monday. So again, we learn relatively complicated kinetics in medical school, or perhaps in nursing school, pharmacy definitely, but we immediately forget them. Absorption is almost never an issue. And exceptions would be some compound like or an element like iron, or in severe malabsorption. Now, Crohn's disease, short gut, celiac, totally different situation. But for the average person, if you put it in your mouth, it's absorbed. Distribution is not really usually an issue. Exceptions, anesthesia or intravenous sedation, which is beyond today's topic. Metabolism, some drugs go to active metabolites. The kinetics are usually similar. There's the odd exception, like the norfluoxetine metabolite of fluoxetine, which is biologically active, has a much longer elimination half-life. But, that's quite rare. And almost all drugs require the liver, or very few, like elements. They'll never change long after we're gone from the world. And the odd small molecule drug like gabapentin, pregabalin are excreted through the kidney. So basically, for elimination, if you wonder if it's liver or kidney, it's probably going to be liver, and then kidney also gets rid of almost everything. So really, I don't think one needs to know much of this stuff. But the average elimination half-life, in contrast, is very helpful. Here's an example. In this case, the helicopter pilot and I were wondering, do we get back in and turn on the rotors or not? But the bear disappeared very fast. So his half-life of elimination was about a minute, something like that. Oops. And here's some examples with drugs where it can be really helpful to know that the time for the drug concentration to reach a steady state at around 4 to 5 half-lives, or if you want to cheat, even 3 half-lives. Pain would be a good example. And a short half-life is very nice, as in morphine, acetaminophen, ibuprofen, because you're going to reach steady state within a day, and you're going to know the effect soon. And most of us know that practically if we take ibuprofen for a headache or severely sore knee or hip or something, and it hasn't worked within a few hours, we take more if we think there's a chance that's going to work, or we switch to something else. Oxygen is a good example. It's incredibly fast, short half-life. So if you put high flow oxygen on, it should work almost immediately if the lungs are working. And if you take it away, the person's going to be blue very fast. And in a dangerous overdose, we would like a short elimination half-life. And alcohol is that way, except that once you saturate metabolism in the liver, then it takes forever to get rid of it. So if you only had one standard drink and that proved dangerous, you'd be in luck because it's going to wear off very fast. Antidotes, you would like it to be as long as needed. Like if you could give one dose of naloxone and it was enough and you didn't have to worry again, or epinephrine, that would be lovely, but it isn't. In fact, they don't last that long. And in withdrawal, if you're worried about withdrawal, a slow elimination would be nice. This relates to the why for fluoxetine, knowing a long elimination half-life is relevant. If the elimination half-life is around 9 days, then the chance of withdrawal during my vacation is very small, and you probably don't have to worry about it. And if it's a short elimination half-life, you may well have to worry about it. And some drugs we use in psychiatric reasons, like benzos or venlafaxine or opioids, that's obviously an issue. And in prevention, rapid onset is very seldom crucial. It might be for an anticoagulant, but say for statins or for blood pressure drugs, it's very rare that you're saving somebody's life by giving it immediately. So you still are unconvinced. You can't understand why I would ever be giving a talk like this. Well, because Aaron made me, but unless drug effects relate more to duration of exposure than to blood concentration, at the peak effect, 3 to 5 elimination half-lives, you're going to know what it does. So if you think, well, yes, but I reached the peak effect of the peak concentration of a statin within a few days, great. It's going to protect me from a heart attack. Well, not really. They probably work slowly. Same perhaps with blood pressure drugs, unless the pressure is absolutely crazy, like hypertensive encephalopathy that none of us have ever seen. But most of the time we're using drugs for symptomatic reasons. If you understand that they're going to reach their peak concentration, and that the effect, say, in the brain is likely correlated with the concentration in the blood, then you can tell fast. And if it hasn't done anything, you can stop it. And you're wasting your time to keep giving it for month after month. And conversely, you know when the effect is going to be gone. So that was the case, the first example I gave you. And of course, if the kidney function is terrible or the liver is very sick, it may be different. Or if you're using a drug like Paxlovid or erythromycin and some antifungals, average may not apply. Those are rare situations. Simple example, if you stop bagging or take the oxygen away, the person is going to be blue within minutes, possibly faster. And, here's an example where on the right, on the left, banging your head further, you can tell rapidly within a couple of bangs whether that's going to help you feel better or not. And on the right, Warren Buffett is saying this could be you. If you start investing now and you live long enough, you may be rich. But it's not going to happen right away. That would be an example of a very long half-life to accumulate or to eliminate. But when you are rich, you'll probably die still rich because you'll never have time to spend it all because it'll have a long elimination half-life. So that's the one gem you can take away. If you become rich, you'll be happy forever. So now we can ask, if you start acetaminophen or gabapentin today, how long are you going to, for yourself, for some kind of bad pain, how long are you going to give yourself? And you can vote now. The point of it is you're going to know very fast. And we were taught, for example, with gabapentin, it became a $3 billion US a year drug by teaching us something entirely false, that we needed to take it for a long time, or our patients had to keep flogging it and pushing the dose. And keep taking it for another month before we decide whether it works. That was completely nonsensical scientifically. And it generally will be for pain drugs. If I were going to try duloxetine, just see if it helped pain somehow, I wouldn't personally, but if I did, I'm going to know within a few days, because the elimination half-life is somewhere around 12 hours or so. You can also, if you don't want to bother to look it up, you can make a good guess. If the drug is recommended to be given once a day, it's probably going to have a half-life more than 1 or 2 hours, right? So here's another common example. If you're treating cancer pain and you're using an opioid with a short elimination half-life like morphine or hydromorphone or almost anything else other than methadone, if the elimination half-life is in the range of 2 to 3 hours, then if we started now, this time on Saturday, at least in Western Canada, by this evening, I would know whether it's working. It would have accumulated to its maximum steady state concentration, which is, it's a good thing to do in palliative care or treating a patient in the office who obviously has severe pain, is say, call me before I go to sleep tonight, let me know how you're doing, or no later than tomorrow morning, let's double check. That's not going to take forever. And here's some examples of common drugs with short elimination half-lives. A lot of what we would use for pain or symptomatic treatment is going to follow that kind of rule. You can assess somebody very fast. I think because we don't have much time, I'm going to not show you this. You'll be able to look at it later if you want. Okay, so what use is this to me? Well, supposing it were today or yesterday, could you just stop a drug? And if you think amlodipine is the cause of edema, and you stop amlodipine with an elimination half-life of 1 to 2 days, by Monday, there still will be at least a quarter of it left if we stop today, and perhaps a half of it's still there. And if it's a sedative drug like methyltrimeprazine or nortriptyline, these are drugs that have often bothered me seeing a patient under the effect of them. If I know it takes 1 or 2 days to get rid of it, if I stopped it yesterday, patient can always call me on Monday if they're complaining about something, or to tell me, my God, I can't believe how well I can see now, or I no longer feel dizzy and I don't have the dry mouth. It might take a bit longer than 3 days to completely get rid of adverse effects. And bisoprolol is a bit in between, but 10 to 12 hours as a beta blocker. If stopped now for bradycardia, we could certainly reassess on Monday. There'd be some of it left, but not much. So if you're still bradycardic on Monday, it's not the bisoprolol. I'm just going to show you an example where this is practical.
Well, this morning I got out of bed and I couldn't stand up properly. And I was struggling to get to my clothes. And eventually, I had to sit down in the bedroom to get my bearings. And then my hands were shaking like hell.
What did your hands look like?
Well, I'd do this sort of thing. Went downstairs, holding the rail and the wall. And then a couple of days ago, I fell off the bike. Took a piece out of my arm.
What did you think was going on?
It's like nervous blackout. To have some damage to it.
I'm sorry, I couldn't understand that. Just a nervous what?
obviously might be a reaction to some of the medications I take, but I'm not sure. Maybe I'm having a stroke.
What was the new drug supposed to do?
Help the pain in my feet because I've got, I think it's neuropathy.
And were you able to tell if it worked or not?
No, I've still got pain in the feet.
Is there any difference in your balance now?
Yes. Well, I'm better balanced now than I was when I came here.
Okay, I'm going to stop that one there, Aaron. I think stop because there's some questions and I see some really interesting ones.
Yeah, so we're right up against the clock, so I'll just share a couple. Okay, but peak concentration or steady state concentration is not always associated with peak effect, is it?
Well, I think it probably is, but I'd be interested if the anonymous attendee, you don't have to reveal your name, but tell us, for example. Oh, okay. So that relates also to the first questions. Why do antidepressants take so long to work? And TCAs, for example, for chronic pain. Well, first of all, in clinical trials, tricyclic antidepressants don't work well for chronic pain. Recent reviews are much less biased than earlier ones. If you look for recent systematic reviews, you'll see that. But in depression, also, if it's untreated with drugs, a typical time for a patient to improve is said to be around 6 to 8 weeks, which is called regression to the mean. You go to your clinician when you're feeling horrible with depression. They say, you know what, I think it's going to get better if we just sit tight. And 6 to 8 weeks later, many people will be better. That's regression to mean. If you give them drugs, 6 to 8 weeks later, they'll also be better. The difference in depression in high quality systematic reviews is about 1 out of 10 people with drug compared to placebo, because most people will get better. I'm not talking about severe suicidal depression with, complete psychomotor retardation, the kind of person who'd be hospitalized and given ECT, but more typical depression. And there's a related question, Aaron, which is why is methadone, if it's a long elimination half-life drug, prescribed TID for pain versus daily for opioid replacement therapy? I've always wondered about that, and I don't know the answer to that. It doesn't make sense. I had some patients, one with horrible cancer who was treated for a year, osteosarcoma pain, was treated beautifully with once-a-day methadone. And I never found anybody else after that who, and it may be that it's just better to split dose because you don't get quite as much of a peak effect while it's redistributing. I don't know the answer. This one, I pressed the wrong button, but it's a good question. The neuropathic pain mechanism of action is apparently different from the opioid mechanism of action. And I think the implication of the question is, well, maybe you need more time with a drug recommended for quote unquote neuropathic pain than one does for another drug. First of all, I don't know, after 30 years, I still don't actually buy that the term neuropathic pain means very much. It's certainly different to have post-herpetic neuralgia or trigeminal neuralgia than joint pain. But the lesson I've drawn is, well, whatever you want to call it, look at evidence and also look at the patient to tell whether any drug treatment is better than not being treated. And I don't think that there's evidence that it takes a long time for a drug recommended for quote unquote neuropathic pain to work. Mostly the experiments measured people at 2 weeks, 4 weeks, 6 weeks. That's a practical issue. And it's also behind it is the interest of the manufacturer that if you sell a drug for a few days, it's not going to make you much money. If you sell it for months or years, then you're really in the clover. So I think my clinical practical advice is if you're trying, for example, gabapentin or pregabalin or duloxetine or a tricyclic or whatever you want to give, assess early, no longer than a week. And if it were a Monday, it might make more sense to do it on a Friday if you work Fridays, or Thursday or Wednesday.
Okay, thank you, Tom.